And I wanted to focus my talk on cardiovascular risk in people living with HIV. And this is a topic that I've been doing research on and we've been paying more attention to as people age with HIV and people live longer with HIV. And we're finding out that they have increased cardiovascular risk and sometimes at younger ages. So then the question becomes, why cardiovascular disease? I mean, this is not an infectious disease. It's not something we were accustomed to being concerned about in terms of HIV previously, because our patients were not living long enough to develop cardiovascular disease. But now we find that it's increasing as a cause of mortality. And in sub-Saharan Africa, mortality among HIV-infected adults has been declining with increased ART use, as it has been around the world. And non-communicable diseases are increasingly contributing to morbidity and mortality among people living with HIV. We found in the US studies that compared to seronegatives, people with HIV have twice the risk of myocardial infarction and more than 4 times higher risk of sudden cardiac death. And a study done in Malawi in the Karanga district found that 4 years after ART was introduced, so this study was conducted in around 2009, and ART was introduced for widespread use there in 2005, almost half of the deaths among people with HIV were attributable to non-communicable diseases. And 27% of those diseases were cardiovascular disease. And this slide looks at HIV-associated non-AIDS comorbidity among people with HIV. It was a cross-sectional comparison in the age HIV cohort, which is a prospective cohort of adults 45 years and older. And they looked at comorbidities, including hypertension, myocardial infarction, peripheral artery disease, and chronic kidney disease. They found that all of those diseases were higher among people with HIV, and that the number of comorbid diseases that people were living with was higher among people, the HIV-infected participants. So if you look at this slide, and I hope you can see my pointer, you'll see that in the lower age group, the people between 45 and 49, about 40% of both the infected and uninfected people had no other comorbidities, no non-infectious comorbidities. But you see that with the people who had HIV, the first group here, even among the 50 to 54-year-olds, which I'm hoping is still relatively young, there was a change, and a larger proportion of those people started to have comorbidities. So instead of 40% not having any comorbidities, after age 50, between age 50 and 54, about 25% of them had no comorbidities, and the percentage who had some comorbidity increased. And if you go over to the oldest of the age groups here, people 65 years and older, you see that after age 65, only about 5% of people had no comorbidities. And the percentage with 3 or more comorbidities increased to 30%. Compared to the uninfected group, where even at age 65 or higher, only 15% of them had 3 or more of these diseases. And looking at, I'm sorry, I'll go back one. Looking at the impact of CVD on MI, in particular, focusing on cardiovascular disease, we had a study where we looked at data in the Veterans Administration cohort. And we saw significantly higher risk of MI among HIV-infected veterans compared to uninfected. So the hazard ratio was 1.48. And when you look at these groups by CD4 cell count, you see that among people with CD4 cell count less than 200, they had the highest MI risk with a hazard ratio of 1.88. And there was also an increased risk of MI among people who had detectable viral load, which in this study was viral load of 500 copies or more, with a hazard ratio of 1.6. But even in the people with HIV who had suppressed viral load and a viral load of less than 500, there was still an excess risk, hazard ratio of 1.39. So it was not as high as if you had unsuppressed viral load, but it was still higher than uninfected veterans. And when you took out all the people who had traditional risk factors like hypertension and diabetes, that increased risk remained and actually was a higher in association with HIV infection, where those veterans had a twofold greater risk of MI than the uninfected veterans who also had no traditional risk factors. I'm sorry, I've got to go back one. When we look at CD4 cell count and CVD risk in some of the other cohorts in the US, we see that in the MAX and Y studies, which are cohorts with HIV-infected and uninfected men and women, respectively, compared to the uninfected participants, the HIV-infected participants with low CD4 had a higher prevalence of carotid plaque, which is used as a measure of subclinical atherosclerosis. The DAD study is a tricontinental study that includes North America, Europe, and Australia. It has only HIV-infected participants and is designed to look at adverse drug effects of the antiretrovirals. And they showed no association of MI with nadir or latest CD4 count after adjusting for traditional CVD risk factors. However, when the New York City HIV surveillance registry looked at this, they saw that there was a 44% higher risk of myocardial infarction in people with lower CD4 counts compared to uninfected controls. Whereas people with a nadir CD4 of 500 or higher, so people who started antiretroviral therapy earlier, had a risk similar to uninfected controls. And so that you see there's some variability in these data, and we'll talk a little bit about why that might be when we get to this portion of the talk where we focus on pathophysiology. This is another study, the AIDS HIV cohort study, that looked at carotid IMT progression and compared it to CD4 to CD8 ratio. So not looking at CD4 count itself, but at the ratio between CD4 and CD8 cells. And they showed, on the left is the group that did not have any progression of carotid IMT, and on the right, the group that did. And you see that in the group that did not have IMT progression, the CD4-8 ratio at baseline, shown in black, was higher than it was in the group that had, oh, here we go again. I've got to pause this. Was higher than it was in the group that had progression. So these are the folks whose carotid IMT progressed or got thicker over the follow-up period of 3 years. And you see that they had a lower CD4-CD8 ratio than the people who did not progress. And similarly at when we look at specific antiretrovirals and CVD risk, now not the CD4, but the drugs that we use to treat HIV, we see that there were variable associations of MI risk with antiretroviral medications. So in the DAD, that's the large tricontinental study where they had only people with HIV, the relative risk of MI increased by 1.16 for each additional year of protease inhibitor use. In the MAX cohort, which is the cohort of infected and uninfected men, when they looked just at the infected men, 80% of whom were virologically suppressed, they looked at carotid plaque by coronary CT instead of carotid ultrasound, and they found no real association of carotid plaque with specific antiretrovirals or with the class of antiretrovirals, so PI versus NRTI versus NNRTI. In a smaller cohort in Uganda, where they looked at 186 HIV-infected patients, subclinical atherosclerosis, that is carotid IMT more than 0.78 millimeters, was present in 18% of their participants, and just over half of those people were on antiretrovirals. And there again, they found no association of carotid intima media thickness with CD4 cell count or with being on antiretrovirals or class of antiretroviral. And one of the antiretrovirals on which we focused a lot is abacavir. And it's been difficult to sort out exactly what is going on with MI risk in terms of abacavir use. The DAD in 2008 first reported that there was an increased risk of MI seen with recent and cumulative abacavir use. And at that time, one of the concerns was that maybe people were being preferentially selected for abacavir instead of tenofovir because of renal insufficiency, and that many of the people who had renal insufficiency also had hypertension or diabetes that would put them at increased risk of MI. So maybe what we were seeing was channeling bias. However, when they repeated the study in 2013, they saw decreased abacavir use in people with high CVD risk, presumably because of the previous data that made providers less willing to prescribe abacavir in people who had high cardiovascular risk. And in this analysis in 2013, they adjusted for renal function, for baseline lipids, and for hypertension, and they still saw that current use of abacavir was associated with a higher risk of MI with an adjusted risk ratio of 1.98. In NA Accord, which is the North American AIDS cohort collaboration that includes the patients in the US and Canada, they again found that recent abacavir use was associated with a higher risk of MI with an adjusted risk ratio of 1.71. However, the Veterans Affairs Registry that includes HIV-infected veterans throughout the US looked at this issue also, and they found no association of cumulative abacavir use with MI. And that still remains an open question that we're not totally sure that we understand what is going on with abacavir. As of now, in the US, providers tend to avoid abacavir use in patients with high cardiovascular risk because we're not sure. The data do suggest that there is an increased risk. And in that case, because of that, if we have alternatives, we prefer to use those alternatives in people with higher risk for cardiovascular disease.